A 9-year-old boy weighing 33 kilograms. He was asymptomatic. Before his admission to our clinic, transcatheter closure of his ASD was attempted before, but it was unsuccessful in another center. On physical examination, there is systolic ejection murmur at upper left sternal border. ECG showed sinus rhythm. On transthoracic echocardiography, there was secundum ASD with left-to-right shunt. 2D diameter of the defect is 18 millimeter, and with color flow it was 21 millimeter, and right ventricle was enlarged. Total septum was 43 millimeter in length, and his aortic rim was 3 millimeter. These are transthoracic views. And our intended intervention is transcatheter closure of his defect with T guidance.
Okay.
Okay, so
ahead,
let's focus on the echo first.
Okay.
This is a 8 years old.
9 years old. We had the history already. 9 years old with ASD.
This is an ASD, and the ASD is not that small. We measured it with the echo 16 by 18 to 19. And here you can you can see the echo. Yeah. This is a 30 degrees angle, and there you have absolutely deficient anterior rim. And if you look at the 120, you see some sufficient rims towards the posterior and the superior part. And what is of important interest is not only the size, but in the 30-degree angle, or if not in the 0-degree angle, you can see. Can you show us the 0 degree?
This is 100. Okay.
Yeah, can you show us? Okay, we can take that. We need a moving picture. Then you see that the quality of the posterior part is very, very floppy.
True.
So we did some measurements. The size of the defect is 16 by 19, 16 by 18. The total length of the septum is in maximum 40, if not 38. Body weight of the child is roughly 30 kilograms, and the size of the defect may be in the color flow Doppler measured by 18 by 20. So what we already did is...
are you going to do balloon sizing, or you are happy with whatever echo you are seeing?
Well, I personally am not happy in any way just doing it, measuring by echo, because the only embolization I experienced was in that case where we didn't any balloon sizing. Therefore, we can focus on the screen now. Can you see the balloon sizing, what we already performed?
Okay, yes.
Can you see that?
Yes.
Okay, what we did first, we inflated, this is a 34 LifeTech sizing balloon, and I learned that the 34 is going to be inflated up to maximum 28 or so. This was the reason why we used this one, and we measured it in a stop flow technique controlled by echo with roughly 20 millimeter, and in the echo we measured it roughly 21 millimeter. So that is the basic information so far.
So can we ask maybe the audience what they think to put? Maybe Omar, what do you think is? Can we have the microphone to Omar? So what device and what size you want to put?
Well, normally, if this would be an adult...
We will give Felix, we'll give the audience chance to...
Okay,
so yeah. Go ahead. Omar is talking now.
Okay, talking's better than sleeping.
20.
That's the idea.
Guys, I wanted 24 I would put, because...
the size is 19.5. This is with a balloon.
They measured also 21.
No, it was measured 16 by echo, and sizing balloon here is 19.5.
And 21 on TOE. Yeah. When they measured the balloon sizing by
21,
scale,
okay.
it was 21.
So you want to put 24. That's, I think, oversized. Shaq?
Well, remember this patient has had one attempt and it's already failed, so it'd be interesting to see why it failed. And I'm guessing it was the angle of the device because of the absent aortic rim. So if from the size that you've got, I would attempt a 22, but with a balloon-assisted method from a second venous access. Or you might attempt it straight off from the right upper pulmonary venous technique.
Okay.
Well, that's something what we have in mind so far.
Okay, we have one more comment and then we let you go, Felix. Go ahead.
Okay.
I would use the same with the shock. 22 will fit, I think.
Okay.
So that's maybe helpful. Okay, go ahead, Felix.
Okay, now I can tell you what we discussed so far. If this would be an adult case, we perfectly would use a 26, if not a 28. But as I mentioned, the maximum length of the septum is roughly 40 millimeter. That means if you would put in a 24, we would hardly have space enough to manage the device within the left atrial cavity. That is the reason why we decided to try a 22, even though knowing that this might fail because of that missing anterior rim of that very bad angulation what we will have. But we can start with a nearly two-thirds deployed occluder in the first attempt, and if that fails very easily, then we start with the right pulmonary vein approach to see whether we can check that. In this situation, I do not really expect that the balloon-assisted method will give us the best option, because I would not expect a prolapse at the posterior superior part, but more or less a posterior inferior part, and this is something what you cannot really easily adjust with the balloon size, with a balloon inflated assisted placement. What do you think about that, guys?
I think once you fill the space of the defect with a balloon, then it really prevents the device from prolapsing. So the left atrial disc has to remain on the left atrial side, and the right on the right side, and then you deflate the balloon. But you know, I think there are several ways of doing this, and it's whichever one you're comfortable.
We can see how we do.
Yeah.
Okay.
Felix, I have a suggestion.
Yeah.
That as you mentioned before, like develop only half of the left atrial disc, and then rotate clockwise slowly, and then deploy the rest.
Well, that is
in 70% of cases, it works with a deficient aortic rim.
Well, that's right. That is my second approach if the first one would fail. I personally love to start with a two-thirds deployed occluder to start, just to see how the behavior of the device is, and that gives me some more spatial information I probably need for management of the device during the implantation. And guys, let's try to start with that.
Let's go ahead, Felix. Let's try to see. So what kind of device you are using?
We used the 22 so far.
And is it an ambulatory device?
It is a Cera-Flex device.
Cera-Flex. Okay.
Stop here.
Felix,
and flush here.
This is David. What about the Hausdorff sheets? If you have a Hausdorff sheet...
We have no access to the Hausdorff sheets net yet here. You flush, yeah? So we are flushing during inflation. Flushing. Still flushing.
Can we have live fluoro, please?
So
Echo and live fluoro.
No,
Echo
no flush.
small live fluoro.
Stop.
We have live fluoro now. Echo, please.
Yeah, I give you live fluoro if you use it. So far it was without any fluoro, but we now change to fluoro, because I love to flush the sheaths during advancement, and now I'm going to live fluoro. Can you see live fluoro now?
No, we want picture-in-picture here. We need fluoro bigger, or this is good actually. That's
okay, so I'm going to advance the device up to the mouth of the left pulmonary vein. Stop.
You want to see fluoro bigger or the echo? Echo is good.
Here you see the device coming, okay?
Yes, we see the device.
Okay, so now I will withdraw it a bit into the left atrial cavity and deploy a bit of the device. This is probably always the case now. I'm still in the left atrial cavity, as you can see here.
It's almost want to prolapse.
Yeah, absolutely, you're right. But I'm not finished yet. So I'm still in the left atrium. Is that okay with you?
Yes, and you are opening the waist, I think. So
yeah, I did. Yeah. So that is something what I tried to come towards.
It's prolapsing now.
It's prolapsing, yeah, okay. Coming back to the left atrium.
Yeah.
Going a bit more to the pulmonary vein.
Right, yeah, right pulmonary. It looks better. This looks better orientation.
Well, but this will prolapse as well. I would expect it. Let's coming back.
No,
It's a
no.
so it's a left atrium. So
Still you are in LA. But
yeah. So now I will start to deploy
now
a
start
bit.
deploying, yes. Yes, you get the disc now. Okay. Still okay.
It's protruding, huh?
Yeah, maybe I think it's small device to me.
Well,
Go ahead, Joe.
I personally don't think it's going to work unless you go into a pulmonary vein. And I have to say, my choice when there is deficiency near the aorta and the SVC is to use the left pulmonary vein. It's a long device enough to be able to do that, rather than the right upper pulmonary vein. But you could try the right if you want to.
Well,
But what do you think, Joe, the device size? Do you think it's a little
Well,
bit...
well,
the
I think
device
24 is, should be better, but we try. Give us.
Well,
give
no,
us.
I think 22 is fine. This wasn't entirely stop flow. On the balloon, there was some waste. So I think this is a big enough size. But obviously, you don't want to pull it through and make the hole bigger. So I wouldn't mess around with what you're doing. I would just try a second technique, which is a pulmonary vein. My preference is the left, but if you want to try the right, you could do so.
I will try the right
I
one.
mean, you want to deploy the device in the pulmonary vein and pull it all the way, okay.
So what I approaching the right.
Pulmonary vein.
What I suggest you do is you pull the device. Are you in the pulmonary vein now?
No, not really, but at the
No.
entrance, at the mouth.
Well, to enter the pulmonary vein, you need to pull the device into the sheath so that the sheath curves and gets into the pulmonary vein. And I think an AP is a nicer projection than the oblique.
That looks a good projection, but it's just... Yeah, that's good, excellent. But she's... Yeah.
Well, I'm not quite sure. I think
mostly, I think, into the LA.
it is good aligned, but it's not really
It's
fixed
all
at the
in-
left atrium. But let me.
You are
let
all
me-
in the LA now.
Not all, but partially. I'm not ready, guys. So give us a chance.
Yeah. I mean, after Omar, we cannot give chance to anybody. We had a heart attack.
Who has the heart attack?
We had heart attack from Omar devices, you know.
Oh, really?
Yeah, you missed it.
So now I'm quite happy now. What do you think about that?
Yeah, now this looks good.
So let's play with the echo now.
Yeah, the echo looks good, I think.
Okay, that's good, because I haven't seen it yet. Let me give a
No,
chance
we
to
have
have
seen the
a look
echo.
at that.
It
Okay,
looks-
please give me a 0 degree, please, first. That is 0, okay. Play with the color flow at the aortic root, please.
Looks good. By
Okay, that looks good. So give us 30 degrees, please. So you see that it is large enough. Shouldn't be really larger for that small child. And this is a case where I personally would recommend a closer follow-up because of that what we have discussed prior to the implantation here. Because this is a patient with a deficient rim in the large occluder in a small body who is definitely at the risk of developing any erosion. But I'm quite confident that the device is in a good position. Let's give us information about 90 degrees. And again with color flow at the aortic root, please. Yeah, here, stop here and give us color at the
looks good. I think Felix looks good.
Well,
superior,
okay.
Inferior limb. Only it is just on the aorta. It is pushing the aorta.
Yeah, well, that's. I think we are
But
right.
this is probably the best you can do it. I mean, the only thing you need to have follow up that
Okay.
it does not cause perforation
Well,
or erosion.
I think we can deploy that device. I would not push and pull too much, just not to lose the position. I'm quite
So
confident that we are in the right position. What do you think,
Everybody
guys?
happy to, I think. Everybody want to go, I think, home.
Oh, really? So I
Yeah,
will.
So they are pushing you to.
So I will release.
Yes.
Okay.
Yes, go ahead. It looks beautiful. Mitral valve is okay.
But it's not released yet.
It's away from, much away from mitral valve, coronary sinus, tricuspid.
You have pushed the red one?
Yeah.
Can we see upper right pulmonary valve?
Right upper.
It's not released yet, but I try hard to. Okay, now it is. Okay. Well, that means for us we are right ready. And you can probably leave the lecture all if you want.
Well,
Any-
good, Felix. I think it looks good. Can we see all the 45-degree angle?
Yeah, can we see 45 degree with the color at the aorta?
No, looks good. So it's just overriding, rubbing the aorta very nicely.
So I'm quite satisfied with the result, and I think we did the job here.
Yeah, I think that looks good. This is a good. I think anybody have comment? I think everybody look happy with the result. I mean, these kind of devices, we don't know if there is any erosion or anything. This new kind of devices, just we don't know.
Well, with this kind of device,
Neurologistically.
I'm quite sure that we will see some erosion at any time, but I think the incidence will not higher with the compared with the others. But as you have seen here, what was really helpful in this case was the flexible connection to the device after it was deployed in this position, and that is something what really helps in this situation.
Okay.
Okay, guys.
Thank you.
Thank you very much.
Thank you.
Bye bye. Well done.
Well done.
You want to go to the other catheter?
Thank you very much, guys.
Okay. Thank you, Felix.